Maybe we get started.
Sure, yeah.
Good afternoon, everyone. Today we have Professor Kaushal Rege. He's from Arizona State University. He's the professor and director, Center for Biomaterials Innovation and Translation, Biodesign Institute, and chair of the Biological Design Graduate Program at Arizona State University, Tempe, Arizona. His group focuses on molecular and nanoscale technologies for tissue repair and cancer. He's published over 100 papers in peer-reviewed journals, in addition to book chapters. He's an inventor on many patents and patent applications, co-founder of Endotat Biotechnologies, which focuses on novel technologies for gastrointestinal health surveillance. He was elected to the College of Fellows of the AIMBE in 2017. He, he has also received a new investigator award from the American Society for Photobiology, Young Investigator Award from the DITRA, and a Fulton Exemplar Faculty Award from ASU. He has mentored over 70 research faculty, postdoc scholars, and grad students, in addition to more than 60 undergrad students. The floor is yours, Professor.
Thank you so much, everyone. Good afternoon. It's a pleasure and a privilege being here as part of the Terasaki Institute seminar series. Really appreciate the invitation from both Johnson and Mehmet. With all your permission, I'm going to share my screen here. Hopefully, that's all visible. Um, let's see. Can you see my screen, everyone? Um,
Yes, yes.
Okay, great. Yeah. All right. So thanks again for the introduction and of course for this opportunity to talk about some of our research. As Mehmet mentioned, we are co-founders of this relatively new company called Endotat Biotechnologies with Dr. Rahul Panala, who's an endoscopist at Mayo Clinic. I won't talk about this, but I'm happy to talk offline. Basically, what we are doing is we're trying to come up with essentially a new product that can be used for gastrointestinal surveillance. As you can see here, this is a pig, and if we have some suspected lesions, an endoscopist would go in and mark those lesions with an endoscopic needle, and either have a patient come in at some point later for surveillance, or they send them to a specialist. And then if you have to reinterrogate, you don't have to go and look at these lesions again. With that ink in place, you can find the lesion, and therefore it facilitates surveillance. There's only one clinical ink that is FDA approved. It is a carbon particle based suspension. A lot of you here are material scientists uh, or chemists, and you can see the problem here, right? This is 65-day data in pigs. It's a quadrant marking, so 4 spots. There's no lesions per se. This was our test. And you can see that the carbon suspension diffuses everywhere. And so you don't get any kind of spatial information. So the lesion could be anywhere, and then let's say an endoscopist or a surgeon would not have any idea where to find the lesion. But with our technology, as you can see, these quadrant markings are very well intact. We have 2 or 3 different formulations in at different levels. We are following up on the company side. So if you're interested a little bit more in this technology, I can talk to you offline. Today, considering where we are with maybe potential interest here, I thought to focus on some of our wound healing as well as a little bit towards the end, a flavor of our melanoma technologies, right? So for those who don't know, we are here in Phoenix, not too far from you in LA. I was just saying that our daughter goes to college in LA. So we are in LA not too, very fairly frequently. Of course, we have the Grand Canyon and our beautiful saguaro cacti. There's the Antelope Canyon, if you've not seen. There's Meteor Crater, where a big meteor at some point hit the Earth. They're not very common on Earth, actually. So you have one straight out of Flagstaff. I'm sure you've seen pictures of Monument Valley. If not, if you've seen the movies, and there's beautiful things like Painted Desert. So there's lots of things to see in Arizona. If you're ever in the Phoenix area, let me know. And believe it or not, we have some water. This is Lake Mead. Of course, levels are dropping. We also have some trees in Arizona, and would you believe it? We also have rain, even though we are famous for being a desert, right? So we are next door, not too far. If you're ever in the area, drop me a line. Would love to catch up and say hi. All right. So I'm going to talk a little bit about our research in broadly in wound healing. As you know, diabetes is a huge epidemic, if you will. 1 in 10 Americans live with diabetes. It's increasing in different parts of the world, including the U.S. It's a leading cause for lower limb amputation. And it's the greatest independent risk for surgical site infections as well. And these are things that are really sobering in terms of numbers. But probably what we don't appreciate is that the 5-year survival for diabetic foot ulcers is similar or worse than some cancers. Here are these DFUs, the diabetic foot ulcers. 5-year survival for all cancers is comparable. It's actually worse than some other cancers, for example, lung cancer here, and maybe comparable, maybe a little bit better than breast cancer, right? So there's 20 to 30% survival for diabetic foot ulcers. And of course, cancer gets a lot of, let's say, news and attention, but this is essentially a problem of the same scale. But what's a big problem? What's a bigger problem in cancer? We have immunotherapies and other chemotherapies that are constantly being discovered and used in the clinic. But as far as biologics go, there have been no new approvals of these for diabetic wounds. In fact, there's only one growth factor, Regranix, that was approved, I think, in 1997 or something like that. So it's been almost now coming up 30 years where there's not a biologic that has been approved. So that not only is the problem huge, the solutions are not forthcoming, right? And so this is a very challenging problem. Several folks, even at the Terasaki Institute, are involved in really coming up with some brilliant strategies to try and approach this problem. And what I'd like to talk to you is about maybe thinking about this problem a little differently and maybe adding to the toolbox of potential solutions. All right, so for those who may be a little unfamiliar, when there's a wound, and this can be any injury broadly, but this is in the context of skin wounds, as you can see, there's essentially the first is there's some bleeding and some hemostasis, essentially clotting. That leads to inflammation. You can see a reddening of that area. And eventually, these are early stage processes, and I want you to keep that in mind. And as the wound starts to close, longer term, there's proliferation of fibroblasts that are, provide collagen. The keratinocyte layer, this epidermal layer, closes, and ultimately there's a remodeling that takes place over weeks to months, right? So there's some of these processes are very quick, within minutes. Some of them take a few hours, and then this whole process goes over months to years. And then the biomechanical recovery, for those who may not know, is never 100%. So for example, when we have a wound that heals, we do not get hair regrowth. The biomechanical recovery is about 70% of the original strength, and so on and so forth. So it's an effective repair mechanism, but it's not necessarily a regenerative mechanism. And that's where a lot of the field is in terms of trying to figure out how the balance between repair and regeneration. So we are not going to necessarily focus on that today, but talk a little bit about these repair approaches. So for example, if you have a small cut or a surgical incision, surgeons would suture that, and that leaves a small scar, as you can see. And then secondary intention, if it's a large wound and if it can heal on its own, sometimes they just put some dressings, or sometimes they just let it heal by itself. In many cases, when those wounds are not healing, then interventions have to be done. And believe it or not, biologics or biomaterials are not necessarily the first approaches. There's things like debridement, there's things like negative pressure wound therapy. And then, of course, the new advanced biologics, when things don't look very good, or when the options are not very many, some of these biologics and biological applications are considered, right? So that's kind of the landscape of what we're operating in. I just wanted to take a little digression before I come into these wounds, and I talked to you about these incisional wounds. A lot of the research in our lab has to do with laser activated sealants in the past. As you can see, this is a mouse that is anesthetized. It has a full thickness skin incision. This is my grad student at the time, Russ Yuri, who's now a postdoc at Michigan. What he's going to show you is a variety of these nano sealants. What happens in these sealants is that it has a biomaterial. Here it is silk. And in some cases, like that was indocyanine in green, we use silver nanoprisms. Or in the end, he'll show a maroon film, which is this one, that has gold nanorods in it. When you shine a laser on these films, the gold nanorods or silver nanoprisms will convert the light energy into heat, and that will facilitate a fusion, a physical interdigitation, if you will, of the biomaterial with the skin. And so essentially, this is laser activated skin sealing. He's placed this film in the incision, and now what he will do is he will use a laser, a near-infrared laser. This is a handheld laser. Of course, the near-infrared light is not visible to us. This pink light is just a guide laser. He's going to do this a couple times on the incision. There's a little bit of art, like in any surgery, there's a little bit of art to the science. He'll do a couple of these, and then essentially that's it. That's the sealing. So it's very quick. It's liquid tight, and it has some advantages, which that it is, as I said, it's quick. It can essentially repair fast and also provide an immediate seal, right? Um, so this is something that we have done a lot about. You can read about this in our papers. And then it's always nice for an engineer when they compare our technology to Star Trek technologies. As you can see, this is some of the older work, but we've done some more as well. And I'll show a little bit of this as we go along. So this was some of the stuff that, as it took a digression on some of these incisional wounds, we have used this technology to prophylactically prevent surgical site infections, which I said was a big problem even today. But essentially, that's something that we continue to work with as a model now. Okay, so coming back to diabetes and wound healing, what causes this dysfunction in the tissue repair? Why do diabetic wounds don't heal? Why do they become chronic in some cases? What's known, very well known, is that there is poor immune cell recruitment and polarization. That means immune cells are not brought into the wound area effectively, and they do not have the ability to polarize and do their stuff. As you probably know, in diabetic wounds, there is poor endothelization or vascularization. So blood supply is not very good, so which actually hurts bringing the immune cells in to do their job. That leads to poor closure, poor reepithelialization, poor remodeling. There's dysfunction in the entire environment. There's other things like reactive oxygen species, advanced glycation products. They all interfere, a higher number of proteases. They all interfere with wound healing processes, right? So it's a very, very messy environment, and that's why you can see that it's pretty challenging in terms of what's possible. Sorry. So from the outside looking in, when we started doing this work, we said, okay, everybody says there's low level persistent inflammation, and this is the let's say thinking in the field that, oh, diabetic wounds are inflamed, so we need to reduce inflammation, right? So that's where the field even today is, and I'm starting to see this very interesting change in approach. And I would like to probably say that we were among the first people, if you will, to start getting into this with a slightly different approach. So what was this approach, right? So the conventional wisdom is low level inflammation. So bring down inflammation and hopefully that'll work. Unfortunately, that's not been successful. And so we said, okay, very naively, can we ask a different question? Can we spike inflammation or mimic early stage inflammation so that we can set the stage for the rest of the drama to happen? So the rest of the drama, as you know, is proliferation and remodeling. So the question is, how do we kickstart what is now called in the field as regenerative inflammation? That means inflammation that can lead to tissue repair, right? Or tissue regeneration. And for that, we have some bioactive materials and growth factors that we talk about. I'll talk about the importance of temporal delivery and things like that. So this is basically the question that we started with, right? Is this really naive? It was. When we asked the question, we were new to the field. There were wounds before us, and people will do wound healing studies after us as well. But hidden in the clinical data as early as 2015, and this is Professor Spiller's excellent work on gene expression in diabetic foot ulcers, you can see that the healing wounds, the blue ones, actually start with a higher level of M1 macrophages, right? Compared to the non-healing ones. Right, so that's interesting. They start with a higher level of M1 are pro-inflammatory and M2 are pro-repair or pro-regeneration. They're also called alternatively polarized. Of course, now people have understand much more about macrophages and their sub-polarization and sub-levels. But broadly, let's use that M1, M2 as an understanding. So some of the first, I guess, evidence, at least that I know of, came here where they look at gene expression, and they saw that in healing wounds, they have a higher level of M2 initially, but that goes as a transition. And if you have this continue, then you get to non-healing wounds. That if you have more M1 eventually, and this is in weeks, you get non-healing wounds, right? Okay, that's interesting. Some other papers, this is, I believe, from transcriptomics analysis, you can see that some of these pathways that are overexpressed in DFUs are also these pro-inflammatory pathways at the wound edge, right? And then something interesting also came by later on, where they found this is in human diabetic foot ulcers. They classified those as healers and non-healers. This is a paper not too long ago now, um, where they found that in the healing group, there was a higher proportion of M1 macrophages. Those are that promote inflammation compared to M2 macrophages that are the ones that promote repair. So the entire thought in the past, or general thought has been, oh, we want more M2 because we want more repair, right? But what's hidden in the clinical data is that M1 macrophages, or pro-inflammatory macrophages broadly, or let's say a pro-inflammatory environment, has a role. And it comes back to our hypothesis, where can we spike inflammation in a temporal manner and have it go away? We don't want it to persist, right? So this is all of this was hidden in the clinical transcriptomics data on human patients that we saw. So our simple question was, how do we kickstart regenerative inflammation? And this is going to be a big chunk of the story today, right? So we looked at what what are the early stages. So if anybody here has allergies, and I do here in the desert, you can see our eyes water, and things like that. And the part of this key role for the molecule that does this is histamine, right? So histamine engages four different receptors: H1, H2, H3, and H4, and essentially increases blood flow, right? And so that's interesting because that sets up immune cells to come in. And actually, what it does is it makes the vasculature leaky and also increases blood flow. And that leaky vasculature, or leaky plumbing, if you will, is partly responsible for all the symptoms that we see in allergies. So it's a key allergy mediator. It is known as a vasodilator, and also it increases blood flow through some nitric oxide synthesis and things like that. I think that it's part of, right? So we started looking at this very simple small molecule and said, okay, what does it do? So as I said, at the site of injury, and not only in allergy, does histamine that is released by mast cells. Mast cells release a lot of different things, but histamine is one of these small vasoactive amine, as you can see. And what it does is it increases, as I said, the capillary permeability, increases blood flow. And because of that, at a site of injury, it brings all these monocytes and neutrophils from the circulation and to the site of the injury. And once these immune cells set the stage, then, as I said, the drama can unfold, and all the pro-repair mechanisms can be initiated. So our hypothesis was, what happens to what if we do with histamine, right? So a little bit more about histamine. All of you probably know histidine, which is an essential amino acid, and you can see that we have in our body an enzyme called histidine decarboxylase. You can see that this carboxylic acid gets chopped off, if you will, decarboxylase by this enzyme. You get a histamine. So it directly is a one-step transformation. It engages four receptors through the histamine receptor 1 pathway. You get calcium activation through other receptors. You get adenylate cyclase, activation of PI3 kinase, and in some cases activation of protein kinase A, protein kinase C, and the like. And what that ultimately does is, as you can see, there's nitric oxide as well. You can get vasodilation, increased blood flow, and immune cell recruitment. So this is essentially just the biochemistry of the histamine receptors. So that was interesting. Are we the first to really do this? Not exactly, but partly yes and partly no. In the sense, people have looked at histamine, for example, in histamine deficient mice, and this is almost 20 years ago now, one of the first papers in mice that came about. And what they saw was, if you have mice that were deficient in histidine decarboxylase, their wounds healed slower. But if you add histamine to these mice, you are able to recover the repair. But a lot of research then kind of somehow, for some reason, really didn't go much further than that. And so we said, you know what, we want to test this, right? In our own transcriptomics, as you can see, this is C57 mice, which are healthy mice with wounds. And these are the diabetic obese mice, which are based on the C57 background. What we saw was HRH1 and HRH2, also the same receptors, did show an increase with wounding. The data are a little noisy. These are our transcriptomics data. We're still analyzing some of these, but at least what it tells you is that there is transcriptional activation of at least the two canonical histamine receptor 1 and histamine receptor 2. So for a lot of you who may not know, histamine receptor 1 antagonists, or something that interferes with their activity, if you will, are essentially the antihistamines that we take in allergy. And if know anybody with some stomach issues, people take antagonists to HRH2, which is basically, I guess, Pepsid, in that. HRH2 is involved in acid secretion in the stomach. So if there's a lot of acid secretion, a lot of acidity, as people would call it, one of the ways to reduce that is use HRH2 antagonists. Just side information for those. So what do we know? Histamine receptor 1 and 2 are at least transcriptionally activated in both healthy wounds in some cases, but also in diabetic mice, right? So there's some involvement. Now, pharmacologically, there's been a lot of research done on these specific histamine receptor agonists. These are all small molecules, which is great because you can deliver a small molecule topically. It can go away from the circulation, which is something that we need to think about as we go along. So we use pharmacologically available agonists for histamine receptor agonism. So agonism would mean that they activate the receptor. Antagonism would mean that they inhibit the receptor, which has different applications, right? We did immunohistochemistry to confirm that in mice, these receptors are expressed. We've done it in different mice, and we've done it in cells as well. I'm going to talk about 2 or 3 different approaches to what we are doing. So I will not be able to give a lot of specific details, but I'm happy to talk offline, or if you have any questions, we can re-engage on that as well. So we did a simple wound healing model. We've done this in healthy mice as well as in diabetic and obese mice. So we have a excisional wound, full thickness, all the way to the panniculus carnosus, which is the muscle layer. We don't punch the muscle layer, but take the skin from above, and then add saline, histamine, or these histamine receptor agonists, and then add a splint in order to mimic wound healing in humans. Mouse wounds heal by contraction, and so in order to mimic as best as possible wound healing in humans, we put a splint that essentially prevents that contraction, right? So this is direct delivery into the wound, straightforward, very addressable. So these are our data with some of these histamine receptor agonists. As you can see, we do much better than this is saline. This is histamine receptor 1 and 4, which have significantly higher efficacy in terms of wound closure. This is at day 11, right? And the histamine receptor 2 doesn't do very well. Unfortunately, the histamine receptor 3 agonist was not very well tolerated. So, but HRH1 and HRH4 agonists did pretty well. These data are reflected in the epidermal gap closure. That means when the keratinocytes essentially try to close the gap and form the barrier function, skin barrier, it is in process towards closure. As you can see, lower epidermal gap. And then there's this interesting thing called transepidermal water loss, or TOOL as it's called. So transepidermal water loss essentially measures how much water diffuses out of the skin. As you can imagine, if there's a gaping hole, as in a wound, a lot of water will go. So for example, in the case of saline, where there's an open wound, there's a lot of water here. If you can see my cursor, the transepidermal water loss is high. In the case of intact skin, because the barrier function is intact, there's minimal water loss. What we saw was we are able to recover a bit of the skin barrier function. So as this is still healing in progress, HRH1 and HRH4 agonists reduce the epidermal gap and restore skin barrier function, right? So now we did immunohistochemistry. So what happens on day 11? We saw that there's a decrease in M1 macrophages and an increase in M2 macrophages. If you remember, I talked about that transition, that you need initial inflammation, and then you need a polarization shift, if you will, a temporal polarization shift towards M2. And we saw that a little bit with these HRH1 agonists, right? So there's some polarization to pro-repair macrophages. But beyond this vascular activity and these immune macrophage polarization, There's other interesting things that we have, of course, it's in our papers, that we have seen that histamine receptor agonists do. For example, in this case, the histamine receptor agonist, one treated mice showed higher e-cadherin loss, which means if you imagine what keratinocytes have to do is that they have to kind of move from their place and then travel along and then close the wound. So in order for them to be able to move from their position, they have to undergo what is called epithelial to mesenchymal transition. This is essentially the same process or similar process that cancer cells use to migrate in metastasis. So HRH1 agonists actually promote EMT, which is a key factor in wound closure. So that's an interesting finding that came out of some of our this work and some other work that we've done. But they also promote myofibroblast differentiation, which plays a role in that last remodeling step when the fibroblasts are now trying to put collagen together and other factors so that the wound can be closed, right? And of course, as you can see across the board, right, both HRH1, 2, and 4 promoted endothelization. So that activity was conserved. That endothelization, all these agonists are able to do, but some of the tissue repair activities like EMT and myofibroblast differentiation is more associated with, let's say, HRH1 and to an extent with HRH4 agonists. So there's a comprehensive reparative response that some of these histamine receptor agonists are able to do. And to our knowledge, nobody's really studied this in detail, and nobody's really shown these other activities that some of these specific agonists can do. So this was interesting, right? So it's not only just based on endothelization, there are other activities for this. I showed you the laser model. Here's a full thickness laser wound. Full thickness means we go through the epidermis and the dermis all the way, as I said, to the panniculus carnosus. And what we saw was essentially similar. We get a pro-reparative macrophage phenotype with HRH1 and HRH4. We see endothelization broadly, and then we see a little bit of EMT. What I will just point out was very surprising in these studies, and that it has led to a whole cancer research inquiry that we have some fantastic results on. We'll talk some other point, is essentially this one finding where HRH2 seemed to not promote EMT, but actually inhibit EMT. So for wound closure or cancer, we need the epithelial to mesenchymal transition, and HRH2 agonist was inhibiting that, which essentially led us to think that that could be an interesting anti-cancer strategy, and which we've pursued separately. But in any case, this is a recent paper. You can read more about some of our work. But the bottom line is, as I said, agonists of histamine receptor 1 and 4 promote wound closure, both in this incisional model and in the excisional model, in healthy wounds, in diabetic wounds, through a variety of different mechanisms at the cellular and tissue level. All right. So I'll come to some other interesting aspects, but one of the things that we saw is, okay, these are small molecules, right? And so the idea is if we put a small molecule, chances are they will go away very fast. And by the way, this is a one-time delivery. We make the wound and deliver it, right? We don't do repeated delivery or repeated administration. So one of the thoughts that we had was, can we eventually, and we are just starting to get there, can we make gels out of these that persist and that can essentially not only activate these pathways, but also maybe play a role in remodeling the environment. We do a lot of biomaterials work, as you know. So that was a thought. So one of the interesting things in biology is polyvalency, right? But before that, we said, okay, this is what the binding pocket of histamine now in histamine receptor 1 is. You can see this imidazolium group that has a lot of interactions, and then there's this amine that has some interactions. So we said, okay, why don't we take hyaluronic acid, directly conjugate histamine to it through this amine group. And also we did histidine because it's a precursor, and we call them polyvalent histamine receptor agonists or PHYRAs, right? And idea is that they would essentially bind to multiple receptors at the same time. Polyvalency or multivalency, as many of you may know, as it's essentially more than sum of the parts. Like if you have a polyvalent molecule, it'll act better than all these individual molecules acting individually, right? So we have a polyvalent histamine receptor agonist. These are some new materials that we've made, soluble to start with, and then gels now that we are working on, right? So the chemistry is pretty straightforward. If you've done any chemistry, and many of you have, We use simple EDC NHS chemistry. There's a reactive amine. We get about 30% degree in derivatization. We call it hyaluronic acid histamine, so HAA, and hyaluronic acid histidine, so HAD, right? So these are the two ones. We have made others as well, but I'm going to focus on these. What we saw was this HAD, for example, is able to activate, and HAA as well, they're able to activate calcium signaling. So there's a calcium flux assay, for example. We've done thorough characterization, but I'm just showing you a little bit of what we've done. And then what we saw that when we did some inhibition kind of studies, we saw that this histamine receptor activation happens through histamine receptor 1, this calcium signaling. As you see, if you use an inhibitor, that calcium signaling goes down, right? So it shows engagement of the histamine receptor 1. Okay, we did some cell transcriptomics to see what are these, let's say, biomaterials doing. As you can see in macrophages, they are activating the cytokine interactions, TNF signaling, which is pro-inflammatory, IL-17 signaling, which is very interesting. That's also pro-inflammatory, and you can see NF-kappa B signaling, which is a canonical pro-inflammatory signaling. In keratinocytes, you can see the same thing. You can see NF-kappa B here, cytokine receptor activation, and TNF signaling. So there's a clear indication that this HAD polymer, in this case, is pro-inflammatory, which is very interesting. And we were able to get that at essentially at a reporter level. There's macrophages that show activity for NF-kappa B and IRF3, both pro-inflammatory. And with this histidine, surprisingly, not as much with histamine, hyaluronic acid, we're able to see stronger activation of NF-kappa B as well as IRF3 in macrophages, right? These are cell studies. Some transcriptomics data also showed IL-1 beta. Now, these are cytokines. It is one thing to activate these transcription factors, and it's another thing to say, okay, once you activate them, do they secrete these pro-inflammatory mediators? For example, this IL-1 beta, this IL-6, and when we did ELISAs, we did see that especially with HAD, not so much with HAA, the histidine, surprisingly, that polymer was able to show an increase in IL-1 beta. You can see this is lipopolysaccharide. That's the control. The others weren't. At these concentration, histamine and histidine themselves weren't able to do it. But this polymer was strongly able to elicit expression of IL-1 beta, TNF alpha, and IL-6, but not the anti-inflammatory cytokines, which is IL-4 and IL-10. So that was pretty interesting, right? So there's some selectivity happening here, which is not possible with LPS. As you can see, LPS activates everything, right? So there's some real selectivity happening, which, to be honest, we don't fully understand in terms of the mechanism. So we're doing some docking studies to see where on the receptor it's binding and stuff like that. So this story is in progress, but it's very exciting that we have a polyvalent activator of pro-inflammatory methods. So in the wound, though, when we did this, you can see, and I'll focus a little bit in the interest of time on the histidine aspect. You can see that the hyaluronic acid histidine was able to significantly accelerate wound closure. The same with hyaluronic acid histamine. As you can see, I'm sorry for that. As you can see, the histidine itself has no activity over saline, which is understandable because histidine is an essential amino acid, right? And these are the same concentration. The concentration of histidine is the same in the polymer as a free histidine. So that shows you that the polyvalent effects do matter, right? And hyaluronic acid does a little, but not really significant, right? So what have we shown? We have shown that we can conjugate histamine and histidine to a simple hyaluronic acid scaffold. One of that scaffold is immunologically active broadly in the sense that they're able to activate macrophages, and in a wound environment, they're actually able to accelerate wound closure compared to saline, compared to hyaluronic acid, and compared to histidine. So the constituent molecules, right? Which is very exciting. We have done a lot of characterization on the immunohistochemistry and stuff, but I'm kind of skipping that. So in this time, we also wanted to see what can happen with some nanomaterial scaffolds, right? So, and there we wanted to go back to histamine studies. These were among the first studies that we did. We used similar model where we have the punch. In this case, we use the silk gold nanorods and we put that on the surface and we affixed it to the bottom of the wound and then add histamine into the wound and then do the same place. All right. So in this case, what you can see, this is in diabetic and obese mice, what you can see is that the histamine, for example, right, was able to close wounds. But then the silk plus histamine, this blue square here, I'm sorry, this symbol seems to have been a little, it is the same symbol but with dashed lines, showed the highest wound healing or wound closure. It's statistically significant across the most part, particularly on later days. And it's a little difficult to see here, but there seems to be a little acceleration of closure, which you analyze separately. So nothing really seems to happen for 6 or 7 days, but then after that, the wound closure accelerates. And we've actually published these results a couple of years ago, so you can see them. And this scales with biomechanical recovery as well, right? So that's interesting that addition of histamine with the silk gold nanorods is able to accelerate wound closure in healthy mice as well as diabetic and obese mice. I'm showing the diabetic data here. What was interesting to us was for those who may have seen this or know about immune modulation, some of the early responders for wound healing are neutrophils, right? They come to the wound area, they eat up the debris. If there's any, let's say, bacteria, they eat up the bacteria, and then within 48 hours or so, they leave. When we did these transcriptomics, for example, that's what we saw. If it's just tegaderm, which is wound dressing, and saline, you see some neutrophils come in, they're there by 2 days, and by 4 or 7 days, they're really not there, right? That happens even in the case of histamine. If you do histamine with this neutrophil, they're there, and then after 4 days and 7 days, they're not there. So they're showing their canonical behavior. What was surprising to us was that with silk and histamine, you saw these neutrophils kind of persist in the wound area, right? So they, what we think is happening is they're coming, and for some reason they're staying there, and maybe they're getting polarized or something like that. So in order to figure that out, we tried to find out what's happening with this silk and histamine. And essentially what we found was through series of immunohistochemistries and similar analysis, what we found was that these neutrophils on day 7 are what are called pro-resolution neutrophils. So I did talk to you about the M1 and M2 for macrophages. There is an analogous N1 and N2 for neutrophils. So the canonical picture is the early neutrophils that come in are N1, that can clear the debris and remove any bacteria. But then in some cases, they might be polarized to N2 neutrophils that might have a pro-resolution factor. So we have other findings about what silk and histamine are doing together. But this was one of the more interesting findings, that this combination of histamine and the biomaterial, nanomaterial, is actually able to potentially polarize these neutrophils to an N2 state, and they persist, potentially helping the wound closure and repair. So that's an interesting finding that was completely unexpected, right? Now, remember I told you that we want to activate inflammation and then come with a strategy for delivering something that is pro-resolution at the right time. So the question of temporal delivery is something that we wanted to investigate. So for example, we deliver histamine early enough where we won the inflammation stage, and then later to activate proliferation and remodeling stages, can we deliver something else? So you can see that early stage, as I said, is hemostasis and inflammation, and then later is proliferation and remodeling. So here we delivered our silk and histamine, right, on day 0, which is the day of the wound. And then we said, okay, what is a good time to deliver a second, let's say, treatment that can promote a proliferation and remodeling or later stages of repair? Is it day 3? Is it day 6? So we went back to these kinetics, if you will, and we saw that the acceleration was day 7. So we said 24 hours before days, and that's why we chose day 6. But then we also chose an intermediate point, day 3. So on day 0, that is a simultaneous treatment where the histamine and silk and the second treatment are given together. And then there is one that is a sequential treatment where you do the histamine and silk on day 0 and something on either day 3 or day 6. So what was that something else, right? So as you know, growth factors are in the clinic and everybody studies growth factors. We have a collaborator at Rutgers, and now we can do this in our labs as well. They have a fusion polypeptide where a growth factor is connected to elastin-like polypeptides. These self-assemble, forming essentially submicron particles that are presumably more stable in the wound environment. But the key factor there is the stromal derived factor or basic fibroblast growth factor that is part of this nanoparticle. And that was essentially what we delivered on either day 3, day 6, or day 3 or day 6 as the sequential treatment, or on day 0 as a simultaneous treatment. I know if it sounds too much, I think this is the thing that you should remember. The simultaneous treatment of silk and histamine plus the growth factor did work, but it still had a little bit of wound open on day 11. When we did that sequential treatment on day 3, right, it did better. The wounds closed on day 11. So it did better than the simultaneous treatment, right? However, when we delivered on day 6, the wound actually closed on day 9. So 2 full days before the simultaneous treatment did. So what does that mean? That means that it matters when we deliver a particular treatment or a therapeutic or a biologic, right? So for example, one of the things that is done is if there's a wound, if the idea would be to deliver a growth factor right away, then the problem might be that it might not be as effective. Sorry, something is showing up. It might not be as effective. But if the temporal dosing is planned properly, that you activate inflammation using something like histamine, and then remodeling using something like a growth factor at a different time, at a different stage of the wound, that might be more effective. As you can see, we were able to close the wound entirely in only 9 days, as opposed to having it open even at 11 days. And then that, to some extent, that scaled with the biomechanical recovery. But the bottom line is temporal delivery matters. Of course, it's a little harder to figure out how to do that in the clinic, and that's a whole different kind of let's say way of doing things. But on a more fundamental level, on a more translational level, it's important that we pay attention to this temporal delivery, is what some of our results are telling us. All right. So essentially what we have done here is we have used different treatments to do inflammation that can then set up the stage for proliferation and remodeling with bioactive materials like histamine or silk and histamine, or histamine receptor agonists, or even polyvalent agonists, and then use exogenous growth factor nanoparticles to further promote the wound healing process. And then NIBIB, which funded the work, highlighted some of this on their website, so we're very happy about that. A nanomaterial 1-2 punch quickly heals wounds in diabetic animal model, right? So that was exciting. I want to take a few more minutes, if I have, just to tell you about a related story, but a different story. We've been working in the area of gene delivery. Everybody probably knows what plasmids are. These are extra chromosomal pieces of DNA, about 90 to 100 nanometers. And Resul, who's a postdoc at the time, and then some other students have now subsequently contributed to this work, essentially started looking at this. So broadly, just as an introduction, quick introduction, when you make plasmid DNA, for those who do molecular biology, you process them through bacteria, you use a QIAGEN kit, you purify the kit, and you purify the bacterial prep, and you get a plasmid. What the bacteria do is they have these two enzymes called DAM and DCM. They decorate the plasmid with methyl groups. This is methylation. This is how generally plasmids are made, right? But there are some bacteria that you can buy and that don't have these enzymes. These plasmids come out, let's say, unmethylated or bald, right? So we started looking at the effects of these on both transgene expression, so just luciferase, nothing complicated, reporter protein, and of course on the immune response. A couple things to consider: the methylated plasmid come out as mainly monomers, and the unmethylated plasmid have a mixture. It's monomers mostly, but there's a little bit of dimer and some small fractions. This may be important, and we're trying to uncover why that is. But just to let you know that this is the population. All right. So we are looking at methylated DNA, unmethylated DNA, nothing fancy like a lipid nanoparticle, no viral delivery, no polymers, no scaffolds. What we do is we just inject them into 4 sites intradermally, just the plasmids, no carriers, and 1 site subcutaneous. So it is simple intradermal and subcutaneous delivery, non-complex, luciferase expressing plasmid. Very simple system, nothing to do with any growth factor, nothing to do with a biologic, just an irrelevant protein and no delivery vehicle, right? What we saw was that wounding enhances transgene expression. So that's fine. That may be expected, right? In both cases, methylated and unmethylated, wounded mice had higher levels of transgene expression. That's an interesting result. And the expression was maintained over 7 days, right? So that's interesting. But what was very interesting to us and partly unexpected, to be honest with you, so for all those students and mentees, please pay attention to surprising or unexpected results, because that could be something that's really exciting. This is saline. The wound in diabetic mice now stay open here till 14 days. Methylated DNA pretty much closely tracks what saline does, so it doesn't do much. There's no biologic. But with unmethylated DNA, you can see, and you can visually see this. We saw this in healthy mice as well as diabetic obese mice. You start seeing wound closure as early as, the kinetic starting as day 7. Not much happens to day 7 and 8 in this particular case, right? The epidermal gap where keratinocytes are closing is lower. Transepidermal water loss is almost the same as that of skin. Not exactly, but almost, but it's much lower than methylated and saline, right? As you can see. So there's significant skin barrier recovery. And then we did these wound transcriptomics. These are bulk transcriptomics, not single cell. We saw that the key factors were response to interferon beta, the pathways that were upregulated, and MyD88 toll-like receptor pathway. What does that tell us? It's pro-inflammatory, right? There's again activation of innate immune pathways. Going back to the histamine story, right? It is these unmethylated DNA are able to activate the innate immune system in mice, right? We did NF-kappa B, and you can see at the wound edge with unmethylated DNA, we are able to get not so much in the wound bed, but at the wound edge, a higher level of NF-kappa B, right? So that shows you that there's pro-inflammatory activation in this NF-kappa B. This is from immunohistochemistry. And the other thing we did was we did wound healing studies in these MyD88 knockout mice. So when DNA is seen by cells, the fact that cells see this DNA that is a foreign nucleic acid, that signal is transduced through MyD88. That's what we had seen here. So we said, okay, what if we do wound healing studies in these MyD88 knockout mice? And what we saw that efficacy of unmethylated DNA was lost, right? So that signal of unmethylated DNA could not be, let's say, transduced to a wound healing activity. So that kind of gives a little more corroboration that we are able to activate these innate immune pathways for wound healing. So now we have a second arrow in our quiver, if you will, to activate wound healing through these pro-inflammatory mechanisms, right? And then, of course, we use this for melanoma immunotherapy. I have only 2-3 slides about this just to kind of tell you what we're doing. Of course, you all know about melanoma skin cancer. Trishita is a fantastic grad student who's leading this work. We did 2 models, and I'll just show you our very bare data. There's lots of characterization that she's done, but I won't be able to talk to you about this. So we make a wound just to model a post-surgical situation, let the wound close. Now here we express ovalbumin in the DNA. This is not luciferase, this is ovalbumin. It acts as an antigen. We treat the DNA on day 0 and give a booster on day 14. That the same day we challenge with B16F10 ova, which are ovalbumin expressing melanoma cells. So the DNA expresses ovalbumin, the body has time to make the antibodies and eventually get T cells into the tumors. And then we track this for 90 days, so 3 months or so. So you can see that if there is no antigen, the mice, unfortunately, the study has to end very quickly because the mice don't do well, the tumors grow very much. Without DNA, same thing happens. A little bit of benefit with the wound, as you can see, sorry, this is without the wound, a little bit of benefit with the plasmid, but when we have the wound, we get a significantly higher benefit. What was not expected with us is that in this case, the methylated DNA did better than the unmethylated DNA in terms of survival. Here we have 3 mice completely tumor-free for 90 days. Here we have 1 out of 6 mice completely tumor-free. These are statistically significant survival over the saline, right? Then we went ahead and did a more complicated model. What we did was we first put, and this was to kind of mimic what may happen in the clinic. For example, these are melanoma cells in mice. We let the tumor grow, then excise the tumor as a surgeon would, right? That excision leaves a wound, of course, and that's where we administer immunotherapy. We call that day 0. We do that twice on day 14 and on day 28, and then carry all these studies all the way up to day 120, which is about 4 months, right? So you can imagine Trishita, right, doing a study for 3 months, one semester, and 4 months, another semester. So this is what we are seeing. Again, we are seeing survival benefit with the methylated DNA regimen. And what we think, and I'll just give you a quick overview. I'm not showing any of the immunohistochemistry or anything in the interest of time. What we think is happening here is that the unmethylated DNA, what we know what's happening here is unmethylated DNA is able to have a more comprehensive immune response, whereas the methylated DNA, through only ovalbumin expression, is able to get a response that is specifically for cytotoxic T cells, which is why we are seeing a better benefit with the methylated DNA. But I'd like to drive home the point. The point is we do simple DNA delivery into the dermis and subcutis, no carrier vehicle, no nothing fancy like a virus or lipid nanoparticle for the DNA delivery, and we are able to see significant survival benefit even 4 months out, right? So that's very promising. We're excited about this, and we have a much better understanding of the comprehensive immune response that the methylated DNA versus unmethylated DNA evoke in both in wounds as well as in these melanoma immunotherapy model. All right, I know it's been a lot, but I just wanted to quickly do key findings, and then we can take questions. So here's what a good wound healing looks like, and in order to facilitate that, I would like to propose to you that early activation of inflammation through either histamine receptor agonists, some of these macromolecular agonists, if you will, and then unmethylated prokaryotic plasmids is helpful, and that can accelerate wounds. Even in healthy wounds, that can happen. We can combine them with the temporal delivery of growth factors, either through scaffolds, nanoparticles, what have you, leading to effective wound repair. And I think it also has some implications for melanoma and other immunotherapy, right? Plasmid DNA is not just for melanoma, can lead to other promising immunotherapies as well, now that we understand the immune system activation a little better. All right, so of course, I'm just here talking on behalf of our lab. We have some new stuff happening in the group on the DNA work for the wounds, as well as on some silk related work for the wounds. So if you have any students, postdocs that are interested, feel free to send me an email. It's very easy, Rege, like the music, although spelled differently, at asu.edu. We are looking to recruit students and postdocs in the fall. So if you have anybody interested, or if you know anybody interested, I'm looking forward to talking to them. Again, I know it's been a lot. Thank you so much for the opportunity to show some of our work. This is what excites us. But I'm happy to, of course, take any questions. And if you have any feedback or any comments, I'm looking forward to taking that as well. Thank you very much.
Thank you for the fantastic talk, Professor Rege. Couple questions came in. One is, what are your thoughts about histamine-induced regenerative inflammation on infected wounds or chronic wounds?
Yeah, that's an interesting point in terms of what might histamine be able to do in infected wounds. I was asked this question somewhere else when I presented, and honestly, we haven't yet set up an infection model in terms of looking at specifically what might it do. But there is some evidence in the literature, probably from and this I had a wonderful discussion with Professor Shafikhani as well. He's, I think, at UC Davis, where there was some discussion that actually the efficacy might be even more, in terms of infection, for controlling infection, because we are able to bring immune cells in So there could be some interesting activity there as well in terms of infected wounds. But as I said, honestly, we don't have any data on infected excisional wounds and what histamine does in terms of clearing that infection. But that's something that's been at the back of our minds thanks to some of these conversations.
Thank you. In the case of a deep wound without any specific matrix, how will it help granulation tissue formation in the remodeling phase? Do you think it may cause a scar?
Yeah, so I think there is, so we are not, it's very interesting. What I did not show, um, well, let me answer that question. Let me take a step back. So there is some activity, as you saw on my myofibroblast activation. And myofibroblast activation leads to collagen synthesis and potential that can lead to, of course, that's kind of the determinant of a scar. There's a study that we did with just like how we have a splint in an excisional wound. What I didn't show those results here. We are still writing that paper up. One of my students made a 3D fabricated device based on Professor Gertner's and Professor Longacre's work in the literature. He made a 3D printed device to kind of mimic splints, but in incisional wounds. So even in incisional wounds, the skin will close on its own. So we made a kind of a splint, a 3D printed device that can hold that incision and not let it just snap on itself, if you will. And there we did some histamine receptor agonist studies. And what we are seeing very interestingly, and we've done some other analyses on these, including transcriptomics, is, and I'll tell you about the key findings in 30 seconds as much as I can, is that histamine receptor 1 agonist actually seems to reduce scarring. What happens is that mechanical load actually, at least in our studies in mice, let's say reduces immune cell activation. And when we add the histamine receptor 1 agonist, it brings back that immune cell activity, leading to, I guess, better biomechanical recovery as well as some reduction in scarring. So we are seeing, and we have to take mouse models of scarring, with a little bit of caution because mouse skin doesn't scar like human skin does. But at least in this model that we have, and it's an unpublished set of data, we're still writing that paper up. We are seeing that with HRH1 agonist, we seem to see less scarring compared to mechanical loading, right? So there may be some benefit yet. We are still trying to fully understand why that is. We see some effects on the immune cell activation, as I mentioned, through transcriptomics, but we're still trying to fully understand why that is. I don't know if that answers your question, but that's kind of what we are seeing in our studies so far.
Thank you. Regarding your wounds, are there any ways to monitor the state you're in? You mentioned the proliferation, the remodeling. Are people monitoring what level they are so that they can deliver at the right time certain things?
Yeah, so that is I guess, a multi-million-dollar question, right? So that is, it's a fantastic question in the sense, yes, we have shown that temporal delivery matters. Trying to somehow correlate a treatment with the right kind of stage that you want to activate is important, right? And I kind of alluded to this during the talk when I said that it's challenging the clinic. Let's say a patient presents themselves. How do you assess that? Now, there could be some ways of assessing it in terms of, for example, in terms of gene expression studies or some canonical sort of biomarkers to see. This is just a thought process. Like, for example, to gene expression, M1 versus M2 markers, right? So you can say, okay, that's the status, M1, M2 ratio, that's where the status is. And if that's the case, then maybe we should stratify the patients to do this. Now, to my knowledge, and I may be limited in this, there are no gold standards for biomarkers for what a state of the wound is. So if folks have ideas about it, ways of monitoring it through sensors, I'd love to hear, because I think that's where we would love to take that part of the work for sure, right? How do we actively monitor and then actively deliver, right? So I know there's some work For example, I think Omid is doing some work at Rice along these lines, and he has some very interesting data. Had some very nice conversations with him as well. Um, but yeah, I mean, I think that's a great question, and I don't think as of today we have a clear answer. But I think folks are thinking along these lines. So if people here have some thoughts and ideas, I'd love to hear more.
Thank you. We will connect with you. Another question is your regeneration of the wound, chronic wound. How about volumetric muscle loss? Can the technologies developed for your regeneration, can it be applied to other things, including volumetric muscle loss?
I think so. I mean, I I don't want to say I'm very cautious about some of these things. I don't want to say, it's applicable for this system, so it'll be applicable for that system. But in terms of, how tissue repair goes, right? It is definitely worth looking at that. Now, it is partly for those kinds of reasons that we also develop the polymers and are now developing the gels. But at a simple level, we should be able to activate histamine receptor and try to activate the immune cell mechanisms for volumetric muscle loss repair. So that should be possible. It's just that it's a bandwidth thing, right? There's only so much that we could do. But that's something that we have thought about, right? And in terms of potential other, let's say, broadly musculoskeletal applications where similar histamine receptor pathways could be activated for promoting repair, and VML would be one of those. So yeah, if there's interest, that could be something good to try.
Thank you. One final question. Are people doing cell-based therapy for chronic wound healing?
I think so. I mean, we are not doing that per se, but people are looking to, like, for example, things like people are looking to polarize macrophages and then deliver macrophages as an example, right? In those wounds. So there are people are doing those kinds of studies. We haven't done any cell delivery. To my knowledge, I think people might also please verify this, but people might also be looking at mesenchymal stem cells in some of these applications. So people are looking at cell-based approaches. Where they are in their clinical kind of adoption, I'm not sure that they have gone very far in terms of routine use. But I think in terms of preclinical and development, I think some very neat ideas there as well.
Thank you. One other question came
Sure.
in. AI is becoming increasingly integrated across multiple biological domains. Where or how do you think AI could best help advance the field of wound healing?
Well, I mean, there are multiple ways to and I'm just speculating. So you can take this as one man's opinion and not necessarily, kind of a final word. But for example, I can give a couple of examples. One of the things that we are talking about is, can we develop AI ML based, let's say, just in our narrow world, right? Can we develop AI ML based strategies for better or more specific histamine receptor agonists that can lead to wound closure? So once we know, specifically for the polyvalent, and that's an active collaboration that we actually have right now. In my previous life, as a grad student, and some of the early, if you look at our paper, for example, in Biomaterials 2014, we published an ML based strategy on essentially asking the question, what makes a good gene delivery polymer, right? We can make combinatorial libraries, screen them. People are doing that with LNPs now. And now that work has come in LNPs as well. But if you look at our paper, we were probably among the first, if I may say so, to ask that question, right? What physicochemical properties in polymers are important for a good gene delivery vehicle? So if you look under my name, 2014 Biomaterials, you'll see that paper probably. So that's one thing. The other thing is, wound stratification, right? So can you predict through image analyses and AI-based approaches, machine learning-based approaches, whether wounds might be healing or non-healing? And there's a lot of interest and research, for example, using, I guess, optical imaging, things like optical coherent tomography and some other imaging to kind of predict and whether a wound will be going along the healing side or a non-healing side. And then there are, of course, some physiological attributes rather that might feed into that. For example, blood flow and other things that you can integrate into those models to predict healing. So that's another application of AI, right? And machine learning approaches. So from the molecular, biomolecular to the actual, let's say, physiological response, I think you'll see more and more inclusion of machine learning based strategies. These are a couple of examples from what I can think of, including what we are just starting to do that I can say at this point.
Thank you. Thank you. Final question. If there's no gold standard biomarker mentioned in the discussion, then how does one move forward and select the sensor based on what parameters? What is
Yeah.
the behind rationale in this case selection?
Yeah, I think I mean, for example, I think Professor Mariana Kanik at Miami had published a paper identifying a few years ago, identifying a panel of biomarkers for wound repair applications, right? That may be worth looking at. There might be a revision to that panel, and maybe that's a place to start, right? For example, in that 2015 paper that I mentioned, they used a panel of what they called pro-inflammatory markers, and let's say either you can call them anti-inflammatory or pro-repair or pro-regeneration markers to stratify M1 and M2. Um, the challenge is, is it too simplistic, right? Are three markers for this and three markers for that, is that enough? But those are the places to start, I would imagine. It's not going to be one marker, to the best of my knowledge. I'm not a biomarker person, but it's not going to be one marker, as most of you will agree with me. It's going to be a panel of pro and anti-inflammatory markers, and maybe that ratio will help stratify whether a wound has a pro-inflammatory or predominantly pro-inflammatory environment or a pro-repair environment, and that may help stratify a potential treatment, right? Whether it'll be healing, non-healing, and some of the predictions from all these transcriptomics data, analysis of these transcriptomics data can feed into this AI ML model and then go back and teach us how to temporally deliver. Is my thought. As I said, that has to be tested, that has to be challenged, and then we'll probably find out how we were able to do this better. But it's a very important question, right? And I by no means did I meant to say that, oh, if knowing the inflammation status of a wound is easy, right? It's a fundamental question that is not very easy to answer, at least not today, but maybe in a few years it might be, right?
Thank you. A long question from the Organs on a Chip group.
Mhm.
You have developed working materials and biologics to and characterize it, and then you're doing animal studies. And there's a big movement to replace animals with organs on a chip. They call new approach methodologies. Do you think that could be useful, or we not, especially made with primary human cells? Do you think that would add some value to this wound healing research?
Yeah, I think there is a lot of a lot of room for this. I mean, I'm a big fan of microfluidics technologies. For those who may not know, I did a postdoc with Professor Martin Yarmush, and Mehmet Toner was also in the same center, and they had the microfluidics center. They still do at MGH, and some of the things that were being done there and by others, right? In at the Terasaki Institute and other places are of course mind-boggling, right? I mean, so first of all, a big shout out to people who work on these technologies. In terms of identifying, what could be very helpful. Uh, I'll give an example, right? There are now these wounded explants, human explants you can get from Genoskin, for example, and not that I'm talking about a company or not, but you can get these explants and you can do those studies. They're expensive. One of those wells is probably costs about the same as 5 or 6 Balpsy mice. I think so. right? Or as much as a diabetic mouse would as of today. So some of those technologies are expensive. The challenge there, and this is where microfluidics would, I think, will be very helpful. I know it's not easy. I've had discussions, and I'm a little familiar with some of these technologies, not as much as you, of course. The challenge would be, for example, one of the key things that I mentioned in the talk is histamine is a vasodilator. It brings in immune cells from the circulation. How do we mimic that on a chip, right? Can we do that? If we can do that, if we can do perfusion of let's say a skin model, so that you can now bring in immune cells in response to injury, and then the immune cells can do that. Or if we can take a few steps, I'm not, please don't misunderstand me. I'm not trying to trivialize anything. It's a concept. If we can do that, if that's an effort that can happen, then we would love to collaborate, right? Because we have lots of, as you said, biologics and things that we would love to collaborate with somebody who's thinking along those lines, because we can see the utility of that. So yeah, absolutely. If we can mimic some of these processes in vitro, ex vivo, then we can, at least at first pass, maybe let's say I make a big library of these polyvalent agonists, then I can screen them using some of these parallel screening methods if possible, and can reduce our I guess dependence on mouse models. So yeah, I mean, I think it could be fascinating if something like that were possible. So
Thank you.
yeah.
Thank you. That's all the questions I have. Thank you for the nice talk, Professor. I appreciate.
Thank you very much for the opportunity. Thank you for all the wonderful questions. And as I said, if you have any other questions, comments, feedback, I'd love to hear from you. Rege@asu.edu. Thanks again.
Thanks.
Take
Take
care,
care.
everyone.
Bye bye.
Bye.